Hello, everyone. My name is Jim Seberg, and I'm the Assistant Director of the Medical Cannabis Research Center at Drexel University. We're glad to be joined today by Dr. Philip Kim. He is the President of the Pennsylvania Pain Society, founder and CEO of the Center for Interventional Pain Spine, LLC. And he's also a triple board certified anesthesiologist, pain medicine and integrative medicine. Dr. Kim also holds his degree in anesthesiology, residency, and pain fellowship at University of Pennsylvania, and holds a master's degree in functional medicine from the University of South Florida. So without further ado, I'd like to pass it over to Dr. Kim, talking about the Pennsylvania Medical Cannabis Program and the opioid epidemic.
Thank you so much for allowing me to give you this talk. This is a field and practice that affects Pennsylvania, affects our practice, affects our patients, and this is a wonderful opportunity. I want to keep this about probably between 30, 40 minutes, give you a lot of chance to give you any questions or comments about this. But medical cannabis and the opioid epidemic have a certain relationship which I want to express. My relevant disclosures: I'm a consultant and a speaker for Collegium, which is a company that produces a product for pain. Cannabis and Agronomed are companies I have done work as a medical consultant and on the boards for medical cannabis products. The opioid epidemic, if you understand it and see where we're at, I think we give you a lot of good information on what led to our policy and practice, and something that we got to be careful not apply the same type of stances and policies with medical cannabis policies. But truth be told, it is an industry. There's policies in this which clearly can help patients and overall this community. Oops. Now, first and foremost is we can all tie in the opioid epidemic started in 1991. You see a rise in prescriptions of hydrocodone and oxycodone. Approximately 1990s, where they introduced OxyContin, a product from Purdue, and you see a rise dramatically in the use of medications for this up to 2013. That has been intertwined with the idea that when you look at the drug overdose death, at that time you see a dramatic rise of opioids. Look on the top from the United States, up to about 70,000 deaths in 2017 in the United States. Over in the bottom here, you see actually broken down just within Pennsylvania in the same period of time. And we would have thought at that time, 2017, that was the peak of 70,000 deaths in 2017. But that's not the case. This is the first wave we saw in the rise of medications, which I believe, again, for the reasons to realize that we also saw a rise in patients been tracked all the way from 2000 out to 2011. About 100 million patients in the US had severe chronic pain. That's about 10 to 20% of the population at that time, about 10 years ago. When you look at those patients, and this is always an issue about this in costs and prevalence of chronic pain, close to $300 billion was direct annual cost at this time, broken down into severe, moderate pain. You can see the numbers that they broke it down per different types of diagnosis overall in 2012. Now, as we've seen this over that period of time, we saw there is a rate of misuse, abuse, and addiction that has occurred. We started to recognize over that period of time. Pragmatic use, if you see this range, is very high, to 1 to 81%. But really the issue that really is concerning for us is the potential misuse and addiction. And I would say on the average in practice and overall analysis, it's probably about right, about 20 to 25% of patients had misuse of the product. Now remember, misuse is not necessarily an actual misuse in terms of for patients. Sometimes a lot occurs when patients probably not take the medications. It's not necessarily an effective probably use it, as you see in lower rates of addiction, which is always concerning when people are using the medications more than its medical use for reasons for a addiction behavior. When we see the rise in the patients, we then start to look in 2012 that there is also a illegal use of these medications. When you look at kids should not be getting these medicines. 55% of patients or 55% of kids are getting these drugs from friends and family. Only about 7% has actually come from one doctor. So you can see a lot of the kids are getting these medicines outside of actually being prescribed these medications, which is a concern in general for this population of patients. As we've seen this rise, we start to realize that there seems to be a red flag. Because again, if we're looking at the fact that we're trying to use medications for pain control, we also have to understand that maybe there is an amount which could be a red flag if the pain is not responsive. If it's difficult in controlling the potential characteristics which are diversion, we have to be aware on when we prescribe this patient, take responsibility on how to prescribe it and who would prescribe it for these patients. This is a study which came from the Group Health, which is an HMO, which looked at individuals, about 10,000 patients, and for chronic non-cancer pain patients, not cancer patients, non-cancer, not acute pain. They identified, as you see, a rise incrementally in the morphine equivalents per day, about 50 milligrams and above. You see a dramatic rise in potential deaths, hospitalizations, unconsciousness, and respiratory failure, which is what has led many societies and the CDC to say there's a warning here we're starting to see on high opioid use and overdose risk with patients. Now, it turns out that there's more than just a morphine equivalent use daily that could cause a risk of overdose and serious prescription problems. So in the VA, over 2 years, about 1,800 patients were analyzed and identified about 817 overdoses or serious opioid-induced respiratory depression. They identified a risk index for overdose, serious prescription, and respiratory depression overdose in these patients. And this is where they came down with logistic regression modeling of these patients, of this analysis. And it showed that opioid overdose and respiratory depression is not just related to opioid characteristics. If you see in the bottom, they also identified that patients had overdose even less than 50 morphine equivalents per day in characteristics. They also identified that it's also related to extended release medications, because a lot of extended release medicines go beyond 20 to 50 morphine equivalents a day. But overall, the characteristic of patients makes a difference. And it means that people with mental health disorders, different pharmacology, concomitant use of benzodiazepines, alcohol, and sedatives have a common effect and cause of respiratory depression and serious overdose risk for these patients. And it does make sense that patients have an issue with metabolizing drug and clearance, so liver and kidney disorders could cause increased risk with this overall. And finally, if you have an issue with respiratory disorder, sleep apnea, where you have very low abilities, and you need just a small amount to cause an elevation in CO2 and cause respiratory issues, you got to be careful, people with pulmonary disorders, for this problem overall. Now, the CDC took all the information in place and recognized that we need to do a better job. As we've seen this rise in the opioid epidemic, this first wave, we can do a better job in education, monitoring, disposal, enforcement. And I would say overall, as a backseat quarterback, saying what they've done a great job on is all this, with exception of disposal. So I don't think people realize disposal of drug is a big problem, because I don't sometimes know what to do with patients. But I do know this: I am not have a license to dispose of medications. When patients bring medicines to my practice, I can't dispose. You have to do it yourself. But you can go to a pharmacy, you can go to a police station, a fire department, and dispose of there if they are able to do that. But CDC has a role, and they've done some things to improve this, because this is their response to this drug abuse crisis. The PA opioid guidelines took all this information in, and they realized that we got a problem for non-cancer patients. So they really made it very specific. This is not for acute pain, so patients after surgery. This is not for cancer patients and end-of-life care. We got to do a good job in assessment and history in these patients. Part of the treatment plan is to recognize patients with risk populations I showed you from the VA study, Now you got to be careful with people with obstructive sleep apnea, coexisting benzodiazepines as sleep aids, because they can compound the risk of respiratory depression and overdose, as well as people with pre-existing psychiatric disorders. And part of that is probably they're on drugs which can cause effects on the respiratory system, including the antidepressants. And yes, we got to look at the fact that when you go past a certain morphine equivalent dosing, we want to keep it under 100 milligrams a day, and ideally less than 60 morphine equivalents is what you really want to be. And they also made guidelines that if you go beyond a 7-day script, you should really be doing a check on these patients. And prescription drug monitoring program, if you don't know what this is basically a requirement within the state of Pennsylvania, across most states, that you have to monitor, and the pharmacists have to put in based on the patient's demographics and what they're getting, so we can check in general and monitor their use. This, by the sense, help preclude patients that may be getting from multiple doctors. People don't realize getting other medications, and this is a really good way across the states and now across the nation, for the most part, to have a monitoring program for the patients. Now, in a cohort of 12 million patients on commercial claims, we realize, and I mentioned from 2010 to 2020, so 10 years, guess what? Opioid prescriptions have dropped about 44% since 2011. But yet, opioid overdose risks have gone up to 94,000 in 2020. And that's interesting, because we thought this all relates to prescription writing for patients and prescribing. It turns out that's not the case. The overdose risks in 2020 is the following. If you look at Pennsylvania, we're at the top 4. The biggest risk is if you look at West Virginia, which is 52 deaths per 100,000 patients. They're the biggest. Then you have Ohio next to Pennsylvania. Then you have Washington, D.C. You have Delaware. Look at their numbers per 100%. They're very high. So Pennsylvania is the top 4 in terms of overdose deaths per 100,000 patients. You break it down further in 2022, you recognize since 2012, we keep on rising, even though prescription drug use has dropped. And we realize, if you look here in the bottom, the overdose in 2021 revolves around fentanyl. Fentanyl, this is not prescription fentanyl, this is illegal fentanyl, but they don't make a claim. I think very little is identified. This is not prescription drugs. This is fentanyl getting across the border, or how it gets to the United States is a problem. And so we're still seeing a rise in overdose, which increased since 2012 in Pennsylvania. What's happened in 2020, as you know, is then we had to deal with COVID. And Quest Diagnostic did an analysis of their urine testing and realized, guess what? A lot of the urine testing, which is done for compliance checks to make sure people are properly taking the medicines and utilizing this, found a huge amount of fentanyl, heroin in their urine test. Amphetamines obviously could be prescription drugs, but cocaine is not. That's not a prescription drug for the most part. So seeing a rise of illegal, non-prescribed opioids being identified in the urines of patients during the COVID time. So what we have now is different ways which have accumulated to the rise overdose 2022, about over 100,000 deaths. The first wave occurred in 1999, which revolves around opioids overdose. Then you see a rise in wave 2, which revolves around heroin, which is illegal. Then you have a rise in 3 with opioid overdose, when most of it relates to fentanyl. Then wave 4 revolves around the fact that we still see a rise, and all relates to illegal fentanyl and a flow of illicit drugs. So mortality and deaths does relate to prescription drugs, but majority of the issues relates to illegal sources, illegal drugs, heroin and fentanyl. So how we got here is always the question. And this is an article where it asks the question, did the FDA ignite the opioid epidemic? And ask the question. Answer is yes. And this is where it comes down to this. In the 1990s, when the FDA allowed companies like Purdue and others, to have extended release medications. They extended its use for moderate severe pain and extended its use beyond just for a few weeks. Even though they have no data past a few weeks in terms of FDA-approved study show it's any more beneficial for a subset of patients. In fact, most of the drugs, opioids, have no long-term consequences or benefits past 6 weeks as far as we have in studies. But yet, the FDA allowed its continued use, allowed pharmaceutical business to market this and tout this to patients that has value for patients with moderate severe beyond just an acute situation. It's interesting, distributors and supply chain knew this was going on because when you look at the top 50 prescribers in the 1990s, 48 of 50 of the top prescribers happen to be in Florida. 40 of 50. They should have known they were prescribing more prescription drugs for these patients than ever in the state. Broward County in that period in 1990 had something like 48 pain doctors in that county. Remember Broward County from all the political discussions? They had 48 of the 48 out of 50 doctors were non-board certified. There are only 2 board certified pain physicians in that period of the time. Yet, supply chain knew this. The FDA knew this at that time. Joint Commission of Accreditation of Healthcare Organizations claimed in the 2012 area that pain was the 5th vital sign. Do you remember this? They made sure that your accreditation, your reimbursement in hospitals were linked on how you manage pain. I would ask Drexel, does Drexel and the hospitals, do they make sure you still measure 5th vital sign? Probably not. That's gone away. But the J Commission made sure that was issued, and that led to the hospitals making policies to make sure they had better control of pain. And commonly at that time, if you had pain less than 3 out of 10, the nurse had to do something. More than likely meant to give them more pain medicines at that time. And I also attribute this ignition of the opioid epidemic also relates to patients. As I showed you, studies show that many of the drugs which are prescribed for the patients got into the younger population, got into the people age of 12 and below, and because they were not properly controlling and locking up their medications. The medical societies were also implicated, should be indicated, as well as physician providers. So let me give you a nice little tidbit from this why. This is an article published in the letter New England Journal of Medicine 1980. And just read it for a second, give you a few seconds. This was published in 1980, and it was motivated by the fact that they realized in about 11,000 patients, mainly these are patients who are in a burn center, there are only 4 cases of addiction documented, patients no history of addiction, only 4 cases out of 11,000. This article was cited about 770 times by multiple societies, multiple pharmaceutical industries to say prescribing opioids for patients has very low risk of opiate addiction based on this study. But if you read it carefully, you have comments that you realize, of course it's very low. It's done in a hospital. Hospital give the medicine to the patient. They're the dispensers, and they will give this to these patients. But yet, if people read this article and pull back and learn about this article, realize, how can you say opioid addiction is low based on this one article, based on this methods? So this to me is one of the hotbeds to me on failure on the medical field, our field, that took this article, no one said much about this, and used this as a means for the policies through the pharmaceutical industry, policy of medical societies, through the FDA, and say this is why we're able to prescribe medicines for non-cancer pain. They will go down in history as one of the historical reasons why this led to the opioid epidemic, this one article, which is still cited sometimes from people on risk of addiction. Then we go down to the idea of patients. And this is where I'm at as a pain physician. I'm seeing this patient with chronic non-cancer pain. What do I tell patients? The CDC has guidelines since 2016. DEA has made these policies. What do you do for these patients that have pain? Now, I'm telling you about patients that are not candidates for surgery. They have no other options. They have chronic pain. What do you offer these patients who have severe pain, non-cancer, have a problem based on this issue overall? Because I would still tell you there's an opioid epidemic. Not just an opioid epidemic, there's a pain epidemic. There's a high number of patients with chronic intractable pain, not responsive to conventional means, not responsive to surgery. What do you offer these patients as a means of pain control? Well, this is where medical cannabis comes in place in the United States. What's happened, and this is dramatic in 2022, is almost all the states have some form of medical cannabis within the states, almost all states. The exception is the one in red, so Nebraska, Kansas, Idaho have no aspect of any legality of any type of medical cannabis in their state. The rest of the states in green are states that have a combination of medical cannabis and now the term is adult use versus recreational in their states. Then you have the states in blue which have medical cannabis policies, as you see, as in Pennsylvania in the blue. Then you have some states in the yellow which have some form of limited access, but do have some form of medical cannabis. So vast majority of states, exception to, have some form of medical cannabis. And I don't want to belabor the non-United States, the Guam, Puerto Rico, Samoa, Alaska, Hawaii. We all have some form of medical cannabis overall in place. Yet, national policy still has medical cannabis as a Schedule I, which has no medical use. But the irony about this overall, you see in the red, October 7, 2023, the U.S. government has a patent on these cannabinoids as an antioxidant and neuroprotective agent since 2003. Which is the irony is we still consider across many policies in the United States that's considered with no medical use. Thank God in 2013, sensible politicians and policymakers started to realize in 2013 we ought to allow more understanding and knowledge of cannabis, let it being used in their states. And that's what's happened overall. Yes, there's back and forth about this overall, but in general, even though it's considered illegal, they're allowing the states to make decisions on the use of medical cannabis across the board. In the top left was policy 2017. You can see how it's changed dramatically, where the red was states that had no medical cannabis or any type of cannabis policy. And you see what's changed since 2012. Over to the right, if you notice in 1913, cannabis was used as a medical use in 1913 at some form for medical use overall for patients. Now, in PA, Governor Wolf signed the medical marijuana program in 2016. This act allowed patients to be registered and the physicians to avoid any criminal penalties if they were to be involved in the use of medical cannabis for the patients. It gave safe access. Cannabis is interesting, and I think I know Dr. Bishop is online here, knows about this very well. He probably gives his talk, and this is why his YouTube talk is going bonkers over on YouTube. Truth be told, cannabis has tremendous medical value. And when I wrote this 2016, there were over 60 cannabinoids identified at that time. Now there's over 200 cannabinoids identified. THC, as you know, is the delta-9 tetrahydrocannabinol. CBD cannabidiol are the big major compounds found in this overall, and there's multiple cannabinoids which are in lower percentages found in the plant, which is value we're starting to learn more about. But on top of it, there's a lot of chemicals, which, you know, especially terpenes, flavonoids, have multiple antioxidant, anti-inflammatory properties, which have yet to really identify as well. We know there's a tremendous value. Because when you look at overall medical practice and pharmaceutical industry, they really identify the active ingredient, the active agent that causes the benefit for patients. And they try to market this, they try to develop this and make this part of medical practice. We do a hard time understanding that maybe cannabis is not just one compound, but multiple. And there's a very famous scientist, Dr. Ethan Rousseau, that identified it may be an entourage effect where all these work together collectively to help patients with certain types of conditions and a benefit for patients for multiple conditions. And that's why I believe a lot of times we have to understand that in medicine, as much as we're trying to break down all these compounds and make a benefit, maybe it's a multiple things we need to look at, different ratios and compounds, and this is where it becomes difficult to study to really get some good science behind it overall. And as much as we're trying to find the magic bullet, it may not exist. Maybe multiple things we're looking for overall with these compounds. Now, endocannabinoid system is a fascinating system. If I break it down to what it does, it modulates the sensitivity of our brain to many neurotransmitters, particularly found in dopamine and serotonin neurotransmitters. It helps with our experience of pain, it helps response to stress. It's a huge type of interaction that occurs across multiple pathways, multiple mechanisms, and what it does for our body. So in fact, you look across the brain, it's found all over the place. Cerebral cortex, brainstem, amygdala, hippocampus, spinal cord, cerebellum, hypothalamus. But here's the thing about the endocannabinoid system. There's very few receptors found in the brainstem. So there's very few regulations of the CBD1 receptor in the brainstem, which is why, and this is actually a reason why marijuana has a very low dose of death when you analyze an LD50. Remember what LD50 means. LD50 is a scientific term in the preclinical studies. You want to have a certain compound, a certain dose, which kills half your mice or half your rats. That's LD50. So for rats, it's about 1,000 milligrams per kilogram that marijuana can be used for patients. You take that number of rats, extract it to humans, that means for the most part, for a human to die from this LD50 for humans, you gotta smoke 40 joints. That's a lot of joints to smoke in a period of time. Or you have to 250 milligrams of dronabinol, which is a synthetic THC product out there, usually for post-op or post-chemotherapy nausea. That's a lot of pills to take to overdose for patients. Now it's interesting over here to the right, compare the LD50, which I find hard to believe, and is water. If you drink 6 liters of water, half the people will die from this. Caffeine, 118 coffee, I can see that. Drink a lot of coffee, it's a lot of Starbucks. What I don't get is the shots of alcohol, because I know a lot more people drink 30 shots of alcohol in a given period of time. It's not me. I've seen it before, and they're still surviving. But again, this is LD50. Probably a certain percentage will die, but that's a lot of alcohol to drink in one-time setting. But I would say President Obama, give him a lot of credit. He's the first to say in 2014, he doesn't think marijuana is more dangerous than alcohol, which is true when you look at this LD50 analysis. And truth be told, looking at this human amount you have to take to die, I think he's right on that aspect. And this is why cannabis is being utilized for medical use, because this risk, particularly when you compare it to opioids of respiratory depression and overdose, is very unlikely based on what we know so far from preclinical data. Which led for recommendation across the board, and I don't have time to go through all this, but the Cochrane Reviews, if you don't know what that is, it's an independent think tank, does a lot of analysis of different drugs, different treatments. Look at this cannabis for spasticity, seizure, fibromyalgia, nausea, and vomiting. You find there's some evidence, something clearly to analyze for patients with the cannabinoids. The National Academy of Science, Engineering, and Medicine published like over 500 pages on this about 10 years ago on the realization that cannabis has tremendous value, especially for pain, especially for seizures, has a tremendous value for patients. And there are many statements of meta-analysis. American Neurology, Canadian Pain Society, American Society of Clinical Oncology, Medical Oncology has seen its value for potential for patients. Yes, we do see it as analysis. We need more studies, we need more analysis, but they do see a role it will play in the future for these conditions. And yet government policy, and we're there, but we don't have federal, like Canada, like the Netherlands. We have state policy like Pennsylvania, but clearly the Canadians, clearly the Netherlands, I include the Israelis, I include the rest of Europe has policy to use medical use for cannabinoids for the patients. Here's an analysis. You want to take a screenshot of this, of different studies. I have this recent as well. But I include this study as one of the reasons why we had this adjustment on medical cannabis laws with overdose mortality in the United States over 10 years. And they analyzed that the states that had medical cannabis laws, which States without medical cannabis laws, they see a difference of a 20% drop in opioid overdose rates in those states over 10 years. This was published in 2014. This led to a lot of analysis and a lot of people doing studies, especially surveys, say, is it possible that medical cannabis use could reduce opioid use consumption? By doing that, you can reduce the patient's potential risk of overdose. Can we do that? One study in Michigan, 2015, doing a survey found there was 64% lower opioid use, increased quality of life, and fewer medication side effects, chronic pain patients, when they had medical cannabis available at that time. Again, it's retrospective online survey with flaws. An Australian study looked at 1,500 patients, a more rigorous study, which prospectively saw over 4 years, they saw no proven outcomes of opioid sparing effects in patients over 1,500 patients, which is a much better study. But yet, there's still questions being asked. Is there any type of sparing effect when you view the data, meta-analysis of the preclinical and clinical data? And I'd say yes and no. Preclinical data are solid when you look at the fact that when you do some of the rat and mice studies, you can reduce ED50 in their studies using delta-9 THC combined with morphine. Human experimental data, most experimental data is looking at cold and pain thresholds are shown a decrease. Some clinical randomized controls show its effect, but it's not as effective for acute cancer patients, but some non-cancer patients have mixed results. Yes, observational studies, some show reduction, some do not, and that's still questionable, but clearly we need more randomized clinical studies to evaluate this. We really benefit patients, particular subset of chronic pain conditions. As I showed you analysis on the reduction in opioids, they also see, if you look at the Part D use in the states, there's reduction in patients with medication for anxiety and depression. Makes sense if you have medical cannabis. And that drug fall costs, when you now analyze in 2013, they were able to save $165 million a year. So you tie in on the fact that I show you some data in terms of its savings. Overall, it's very helpful when you know how much chronic pain utilizing costs in the United States in terms of overall consumption for the medical budget overall. In PA, we now have laws and use of medical cannabis allows patients to get access to pills, oils, topicals, vaporizers, nebulizers, and the flower. Physician role is really, for the most part, certify patients. They take a course online, they get certified, they're able to certify patients. My biggest concern of physician role is I do unfortunately find a lot of people are certifying patients, but if you really read the laws and the regulations, it really wants physician involved with its proper use for patients, how it benefits them, doesn't benefit them, is there any possibility of addiction and misuse in these patients, is there any interaction with the current drug, so it is a drug, to interact with the drugs. You've got to be very careful, especially with people on transplant, people on potential use of different drugs to prevent their HIV as an example. You got to be very careful how it interacts with their drugs overall. But PA medical marijuana laws do not trump state laws. You got to be very careful with simple laws. Employment protection is always a fascinating issue overall, because if you're a nurse, you're a truck driver, you're a pilot, you cannot be taking medical cannabis, even though the state says so. The national laws will trump state laws, and it's a big issue overall. Now, this is the current indication for medical cannabis in the United States. Over to the green, I would tell you in the green, there is really good preclinical and clinical evidence and ongoing clinical evidence shows value for people with spasticity, HIV neuropathy, tractable seizures, neuropathies, Parkinson's disease, and basically the neuropathic conditions overall. And quite frankly, in Israel, Canada, EU, they utilize this very much for these patients in general, use of medical cannabis products. The ones in the yellow, in my opinion, have really no good clinical evidence, although there are case reports and also anecdotal evidence has value for these patients. Ones in the yellow there are some progressive preclinical and some potential value for these patient conditions. One's in the dark yellow, opiate dependence, terminal illness, anxiety disorders, Huntington's disease, multiple sclerosis, disconnect disorders. Yes, it has value, but it's not been established in the clinicals or preclinical data, but it's still an indication as of 2012. As we go on the goodness on potential medical value, we still have to recognize the prevalence of drug use dependence in the general population. This is still quite old, but does have value to look at the fact that people who use tobacco, alcohol, marijuana, tranquilizers, cocaine, heroin. It's interesting to me that heroin, which is basically opioids, have a higher prevalence of people get dependent, which is why it became an issue when you use this drug across the board, the opioids. Marijuana, as you know, in comparison to heroin, much less dependence, but it still exists. You got to be careful for your patients. And tobacco, as you know, is always an issue. Alcohol, we all know this issue across the policies. But keep this in mind, the fact that medical cannabis and potentially more than likely we may go to adult use. We got to understand that medical marijuana here in Pennsylvania. I think as professionals, understand the implications of history. We got to learn what happened to opioids and how it stretched from 1990 to now, how we understand its use still has value for patients. We need leadership. We need legislators. We need the proper business people and really get good public policy. And that's my last slide. I thank you for your time. I really appreciate spending the Wednesday with me on this. I'm going to leave it up to the rest of you guys if you have any questions.
I do have one question for you here, Dr. Kim. If you could go back to the last slide, talking about addiction. One of the questions that came up and just kind of thinking about this, I was speaking with Dr. Peter Grinspoon, who had given a talk with us earlier, I believe it was in this past January, talking about problems within DSM-5 and the CUDITR, specifically revolving around medical cannabis patients. And for those of you who are not familiar, DSM-5 and CUDITR, you have to have two, at least what Dr. Grinspoon was saying, you have to have two of the criteria of the 13 to 15 or however many it is criteria. And one of them is, have you increased your dose? And then do you use every single day? So I'll tackle the increasing your dose. Doctors typically tell their patients, start slow and low, increase your dose until you find what's right for you. And then do you use every single day? If they also have a chronic pain condition that is bothering them every day, kind of definition of chronic, do you see that being kind of a significant confounder within that 9% number? I know that Dr. Grinspoon had kind of pointed that out and kind of wanted to get your perspective on that.
No, that's a very important point because every drug here, tobacco, alcohol, marijuana, tranquilizers, cocaine, heroin, develop dependency. You will develop dependency on any drug. You develop a pharmacologic tolerance to these drugs to get its benefit effect for patients. But as you have a condition, let's say that condition is stable, let's say pain, and that's stable. It's not going away, it's just there. You can acquire more to achieve a response to that drug. But does that mean that patient has dependence, or is that issue of addiction? Or is it an issue of pseudo-addiction, which is a controversial term, as they require more dose of medicine to get the same effect? It becomes an issue with addiction when the patient starts to realize they're using this more than just their condition. Because I have plenty of patients that use opioids, not just for pain control, but they use it for helping them sleep, helping their anxiety, helping their depression. That's why there's a high prevalence of people with chronic pain, with addiction, not addiction, but depression and anxiety. So as much as the DSM-5 criteria exist, when you have an analysis on patients, you ask questions in the real world, is this patient addiction? Is it dependence? Or is it pseudo-addiction? And sometimes it's a art of medicine to ask those questions where they're at. And sometimes you got to tell patients, we got to maybe cut you down or use less, especially if they're having a benefit and or untoward side effects of these drugs. And that's where you got to be careful on the use of marijuana for these patients. Did that answer your question?
Yeah, definitely. If anyone else has any questions, feel free to put them in the chat, but I do have a list here on my own that I can certainly run through as we wait
Yes.
for those to come in. So this was coming from one of the professors on our team talking about just kind of things that people should know. I know that you had mentioned specifically for the opioid use disorder as one of the criterias for the Pennsylvania or qualifying condition for Pennsylvania medical marijuana.
Yeah.
Can cannabis be used in place of methadone or buprenorphine, medically assisted treatments? And then also talking about kind of conjunctive therapy, if you could say a little bit more about that.
Well, the opioid use disorder is, to me, a problem because it also means there's behavioral actions with that patient that use the opioid uses beyond just for a medical condition. I mean, we try to break down, say we're using this for pain control, for example, an opioid, and they're starting to use this for any other part of it, and it becomes an opioid use disorder. They're using the drug irregardless of their pain issues, they're just taking the drug. And sometimes you be careful because there are people and patients that take drug and they find they are not taking for a period of time, they go through withdrawal. They have withdrawal symptoms. Much to you and I that drink, like me, I drink 4 cups of coffee a day. I mean, if I don't have a cup of coffee every day, I have withdrawal symptoms. I'm tired, I'm a little slow in terms of response, and then I get a cup of coffee, I'm good. But patients on marijuana have the same effects, especially if they're using it on a regular basis. So truth be told, on all these medications, we want to use just the minimum amount required to achieve a response to them without them going too far. And sometimes a lot of these patients, you go through a holiday where you stop the medicine, so you don't take it only when you need it. And I profess that with all these drugs, the marijuana, particularly the opioids, to only take drugs what you need, and sometimes you gotta not take it for a day or so and to re-equilibrate the receptors. And that's a common practice with opioids, and it's common practice should be with marijuana too. But people use it on a regular basis. I really profess them to only use it what they need and only get its effects. Now, if they're trying to get high and they're trying to use this beyond opioid disorder and get that effect, and that's what they're looking for, that will probably lead to more problems with addiction and dependence for sure.
Great. So we have another question here from the audience. Brought up many points surrounding like legislation and like lack of clinical data, seeming like a never-ending cycle, specifically as we talk about federal laws blocking it. And this actually kind of relates to another question that I have. Is there any way, based on current federal law, to kind of circumvent those blockades? I know that we've kind of talked about applying for DEA licenses and things of that nature. But how can kind of academic and research centers conduct valid research without having kind of legal access or being plant touching or any things like that?
Well, that's the problem. We're bound by the scheduling of the drug, Schedule 1, and the states, um, the licensing for clinical registration is necessary to be able to get the medicines. Yet, as a class 1 drug, we can't get this. You can't even bring across state lines. Get caught mailing this stuff is considered illegal. Imagine patients that are trying to go to their family in New Jersey or Delaware or across the board. They can't bring the medical products. If they get caught across state lines, that could be an issue in that state. We may not have reciprocal laws that may find that they're carrying an illegal substance. I mean, look. I mean, this is not the best example, but look at the person, the basketball players in Russia. What's happened to her? So, truth be told, I think policymakers from the federal and state have to understand medical marijuana has value. It's there. We need to regulate. We need to use it. We need to get the ability to do studies. But to limit us in terms of the scheduling to get the access to these drugs and is a problem. The IRBs, especially the independent IRBs, so I'm used to the Western IRB, they're coming a little more open to do the studies, but you have to do this in many parts within a university. But I wish they'd make it easier to study. If we get more studies, we'll learn more about this and what really can be beneficial for and who will not. But we need more of this to give you much more guidance to us as clinicians where we can use this and help serve our patients.
Yeah, so that actually kind of leads nicely into a follow-up question here that we have. talking about kind of President Biden's recent announcement about ordering the Department of Health and Human Services and DOJ, Department of Justice, to review the scheduling of cannabis. In your opinion, kind of for research moving forward, for policy moving forward, which would be the best in terms of would it be better rescheduled in a different category, descheduled completely, and then followed up with legislation? How do you think, as a researcher and a chronic pain specialist, that would be best served?
Well, I think I would like it to be controlled, not descheduled. But at the same time, if their policy is to set more of adult use aspect of this drug, that'll be fine from that perspective. If they regulate it as a 2 or 3 or 4, that'll be fine from my perspective, because it will allow us to get access. You won't need a special license, be able to study it much in depth, not be dependent on a clinical register. So then you open up a lot of people that have been interested in studying this. It will allow pharmaceutical companies to study this and learn its potential value for patients. And that will bring a lot of money in terms of doing the proper funding and research. As much as I made a lot of comments about the pharmaceutical business, they can really bring in a lot of money to properly study this and get the proper guidance, and that will help us overall. So I'm open to both. I just want it to happen because we've been again, I show you up front here, this is what's in practice in 1913. I mean, it has a role to play. I mean, we didn't get rid of opium, we used it. We manufacture it now, we have its proper use. Yes, it has done a disservice in policy in the 1990s, but we now still know it's needed for patients. We need the same thing with cannabis. And until we get to that point, we got to learn this. But to also, in my opinion, I just don't see how anywhere different it is to tobacco and alcohol for the most part.
Great. And just a request in the chat here, can you go to the slide with the citations for screenshots? We'll just leave that on that while I follow up with another question.
This one, I think you meant. I think you meant this one.
Yes, that one. And then another question that we have is, does cannabis relieve acute pain, chronic pain, or both? And can it be used in place of opioid pain relievers? How would you kind of parse that out?
So what I would tell you, acute pain, there's really no studies that show major benefit for acute pain. A lot of studies come from Germany. When they analyze for acute pain patients, there's really no studies which show any dramatic benefit for patients for acute pain. They're studying right now. I know some observations. I didn't cite them recently in studying for acute pain, but I don't know anything majorly dramatic which says it helps for acute pain. Acute pain for me is people post-op, so after surgery, because that's one of the best types of methods where you study acute pain after incision pain. And there's no studies I know which shows benefit from that for acute pain. Now, chronic pain is broken down into non-cancer and cancer pain, but cancer pain is also hodgepodge of many types of conditions overall, even non-cancer pain. When I break down non-cancer pain, I look at the ones which have benefit. If I summarize it, it seems to benefit people with a neuropathic pain, a nerve-related pain, like a neuropathy, like a shingles, like a postherpetic neuralgia. I would tell you they have some benefit, and that's where some of the studies for multiple sclerosis and the use of GW pharmaceuticals developed their Epidiolex, which is a 1:1 CBD THC preparation, has been a value for patients with some neuropathic pain. And that study's coming out from the UK. That study's coming out from Europe, which shows is a value for patients. I think that's, of all the chronic pain conditions, that seems to be the most beneficial based on the studies. The Cochrane Review talks about that as well. Policies are done so, especially in Canada and Netherlands, that look at that per se. But again, United States, we're not there. We don't have a national policy in this overall. I hope that answered that question.
Yeah, definitely. Now, just to hop to another question here, talking about withdrawal, so on kind of the same topic of opioid use disorder. Is cannabis an effective drug um, to treat withdrawal symptoms from opioids and that?
So there are anecdotal reports, and people utilize in medical marijuana, and I don't have the reference in front of me, I just saw them, which showed there may be a value use in medical marijuana products to help with some withdrawal symptoms overall with opioids. And they're just anecdotal. They're nothing major than a case series, a case report here and there that utilize it, which makes sense to me for patients. Um, but nothing major in terms of a major prospective retrospective analysis says you can use this to help with opioid withdrawal symptoms overall.
Great. In terms of, I know that you had some kind of the criticisms in the PA-MMJ program, talking about kind of how there is a pseudo recreational program with people just getting certified. Do you think that adult use cannabis would kind of help out the PA program to be more medically focused, to kind of concentrate that for people who are really seeking, specifically as we see that cannabis is less harmful than alcohol, kind of substituting it out recreationally for that adult use group of people, and those tend to be also the people looking for those highest THC percentages. I know that I talk to a lot of people, specifically medical patients, who are really looking for that relief in a medical controlled environment, working with their doctor. That it's difficult for them to find their products. And
right.
In your opinion, do you think that it would be good to have those two programs separate so that we can really focus in on the medical benefit in the medical program?
I do, because ultimately, I think the physician or clinician role is going to change. Um, as much as I like the fact you have to register, take a course for 4 hours, that's not enough time. I spent probably 15 years in talking to people in California and San Diego, University of San Diego and Davis, about their use in the patients 15 years ago. But it's a process where you have to start asking patients questions. This is the art of medicine. Ask them what they do, how they benefit, what seems to help them, what doesn't. And you really got to keep that in your background when you start to understand this role. I do think we need more studies. We need more courses that will help physicians understand cannabis products. You need someone like Mike Bishop to help you understand the different forms and different products, because each drug, whether you use an oral form, a inhaler, or vaporization, this is new to everybody, even topical. And we don't have any good guidance overall on what to use, other than I can read stuff from Israel. I can read the policies in Canada, which talks about its use and amount. But you really got to delve into understanding these patients and learn about this. And that's where the role of physicians is very important to learn. And even though when you get a certificate, you have to see if it really helps them and ask questions. You have to rule out, is there an addiction, a misuse disorder, and how they really benefit, and what it's done for the rest of the body. And that's where that role is going to play a major part of it, because truth be told, we still do the same thing and take care of patients whether they use alcohol or they smoke. We do that still. We still take care of them. We just got to learn the results of those drugs on their body. When this goes recreational or adult use, this medical marijuana hopefully is here to stay, because people still need guidance on what it's doing to their bodies. And that where the physicians and the medicine has to really understand that, whether it's something we are dispensing or whether we're utilizing this, we're going to have to know it anyways. And that's where we got to get involved and understand. And that's where the medical societies have not gone to a place at a national level, which is true, to really adopt this and have this, because of the issues with this being a federal law against us. That's one of the problems. None of the medical societies want to put this on their books because it's not a federal approved drug. That's another problem. If they pass and make the scheduled drug, then you'll see all the medical societies across the nation putting this in terms of their education efforts, rather than have different specific societies, like Society for Cannabis Clinicians as one society, that allows us to learn about this and keep doctors up to date on its potential value for patients and its proper use.
So to follow up on that, and this is a question from Dr. Lincoln now, it just, thinking about stigma and understanding that it's federally illegal, you're saying that that being a big barrier, like if they change that one day, it'll be like the floodgates opening in terms of acceptance. Do you think that there is still kind of that lingering stigma, or how much of that lingering stigma is there within pain specialists and doctors that you work with, and kind of firsthand knowledge that you have?
I mean, to add another possible concerns for this is reciprocal laws and employment protection is a huge issue, which if you're the physician, and they're asking these questions, this is the truth. When you use medical cannabis or any type of marijuana product even for adult use, you're not supposed to, example, if this is important to you, own a gun. You can't have a concealed carry permit, but they don't know that. You understand that you have on medical cannabis, you're on a list. On that list, they may have potential. There's also possibilities of legislating and looking at the policy of driving while using medical cannabis products. That's concern. It also affects your job. What does it do for your job? Does it mean you can't use medical cannabis if you work as a truck driver, nurse, a pilot? The answer is no, irregardless of medical use. But what if you actually, I mean, that's an issue that I don't have an answer for. What does it mean for life insurance policy? What does it mean for disability insurance policies? Will they take it away or adjust it based on your use for these products? That's unclear to me. I don't have answers. No one gives me answers for that.
And what about the perception of about integrative medicine, integrating cannabis into medicine amongst doctors? Is it accepted, or is it still kind of?
It's not accepted. It's not. I mean, from my field, because I deal with this very specialized group of pain patients, I do. But beyond this, overall, it's not. I mean, you ask your doctor, ask them about medicals. They say okay, but they ask them much about it. They don't know much about it. Nobody does, and that's one of the problems within the field. Because you look at all these indications here, someone's going to be managing this patient's condition. Who's going to tell them about these things? Now, you can argue terminal illness, no big deal. People with cancer, no big deal, because the end of life. But what about these other conditions? When do you decide to use medical cannabis versus other drugs for these patients? When do you decide not to? What's the problems? What's the interaction? That's what people don't have answers for. But I do believe that people certify should start to understand this and start to help patients understand this, because that's the question they're going to ask us.
And how do you think, in terms of kind of thinking about some of the barriers to those follow-up visits? One thing that I can think of right off the bat is the acceptance of insurance, and as we look towards federal, getting those kind of follow-up visits to do those checks, and talk a little bit more about what that might look like, or what you would hope that it would look like.
So what I know for patients is most people certify cannabis, and a certification, they'll probably a flat fee, cross-border fee from $150 for $500 to certify. And that role should be, in my opinion, certifying, but also manage them afterwards, because you're meant to basically do a PDMA, so a prescription drug monitoring check from them, make sure the proper use and make sure proper use, discuss this overall. And if any concerns on proper use and dose guidelines, yeah, I would consult the pharmacists at dispensaries, like Dr. Bishop, in terms of its proper use, or what they would use. But you should have real guidance on dosing and what you expect in terms of potential side effects for those patients. But truth be told, many clinicians don't know this, and this is what they have concerns about. They just don't have the knowledge for this. And when you look at these conditions overall, it's a problem. I mean, ask your neurologist, ask your oncologist. They some are more knowledgeable about these things, but many are not for this overall.
Great. And one part of the question here, from one of the people in the audience is, to your knowledge, have there been any studies showing the effectiveness of various forms of consumption for treating pain, like the difference between vaporizing versus edibles or capsules or topicals, things of that nature?
So if you look at all the smaller type of clinical randomized studies, it really is on the use of vaporization or vaporization, or using the flower. There is a Dr. Abrams, Dr. Barth Wilsey did the initial studies and identified that when you look at certain percentages of THC versus different ratios have a value and benefit for patients. So they're doing a dose response curve on the vaporization. But I would argue for the oils, the pills, very little studies have been done for this. Topicals, very little studies have been done for this. Yet they've been in use for patients, and I think that's great. But we need more dose response now. So we need studies on we need studies to show that this how we dose it. Because as a physician, I want to have a guideline, a dose, whether it's based on weight or based on different conditions, how much to give, what are the side effects, what are the benefits, what are the interactions. Like any drug we have, if you look at any drug in the United States pharmacopoeia, you see that every drug has all those things available for us to look at and read about. And that's where the FDA has played a role. But since there's no one really regulating the cannabis use federally, that's just a problem.
Great. Well, I think we're just about on an hour here. Unless there are any other questions, feel free to throw them in the chat right now, but definitely wanted to take the time to say thank you, Dr. Kim. Very informative here, and definitely looking forward to the continued work that we have at the Research Center going on, that you're a part of on our community or our scientific advisory board. And definitely wanted to say thank you for your time.
Always. And anyone has any questions, please feel free to get me in touch with through Jim or send me an email. That'll be fine. Thank you so much, everybody.
Sounds great. Thank you very much.